Welcome to the Inside Knowledge for people with IBS. I'm Anna Mapson. So welcome to episode 157. Today I am joined by Alex Orfanides. He is a UK registered osteopath who specialises in working with people who have hypermobility disorders. And we're going to get into lots today about what that is, how you might know if you had it, and what digestive symptoms it can be related to. She is so knowledgeable on this subject, having just written a book called Help, I'm Hypermobile. She also has a podcast by the same name where she interviews people who have lived experience of living with this condition. And she is just brimming with passion for this subject. I think you're really going to find this a helpful episode if you are hypermobile or you suspect that you might be. Hello, Alex. Welcome. Great to have you here.
Hi, Anna. Thanks so much for having me on today.
Amazing. So I thought it'd be great if you could just start with a little bit of background about your work and what you do.
I'm a UK registered osteopath. So what that means is I'm a musculoskeletal professional. And to be clear, I'm not a medical doctor. So there are doctors of osteopathy in America. They are different from osteopaths in the UK. But I am a registered healthcare professional who specializes in helping people with function and sometimes pain relating to their muscles and joints. And I do that through manual therapy. So sometimes using my hands to treat patients' pain or areas of dysfunction. And also through prescription of rehabilitative exercise and just helping from a general support perspective, whether that's referring to a professional like a surgeon or helping them maybe have productive conversations with their GP.
Yes, great. And today we're going to talk about hypermobility. So how did you kind of specialize into that out of all the physical ailments, that people could specialize into?
It's a long story, but I'll do the short version. So I should have known I was hypermobile my whole life. And you'll hear from people like they kind of did, but they kind of didn't because it got dismissed for so long. But in terms of my career, I started off working with professional athletes. I was working in a very sports-based setting. And eventually over time, I kept dealing with kind of the cases where people didn't seem to get better. They'd end up with me somehow. And then I was the person who, often was able to help them have that improvement. And I started to say I specialize in treating complex, chronic, and treatment-resistant injuries. And I still remember the day I typed that into my Instagram bio, because that was when things kind of changed, because I didn't know just how overlapping complex, chronic, treatment-resistant injuries and generalized joint hypermobility, hEDS, HSD, these kind of acronyms, which we'll get to more in a second, how common they are in that space and how much these types of injuries affect these patients.
Okay, yes. So that would be great if we just break it down a little bit. Like, what is hypermobility for people?
What is hypermobility? So for the long version, I did write a whole book on this. It's called Help, I'm Hypermobile. I go through it in detail. But for the short version, okay. So hypermobility is a physical property that connective tissue can have, where it stretches further than it should. So if you think of a rubber band, it should have a certain amount of stretch and a certain amount of recoil. It should kind of go back to how it was. With hypermobility, we get tissue that just goes too far and ends up having an uncontrolled range of motion. Hypermobility is different than flexibility. I do want to stress that because those two terms get used often interchangeably. So flexibility describes when we have a range of motion which has been developed. It's something which has been acquired through careful, training for the splits or developing that skill set. And we have involvement of muscles around the joints controlling that range of movement, so that element of control. Whereas the hypermobile person who can do the splits is someone who is just able to drop into it since childhood almost. So they have that uncontrolled, just naturally available range of movement, which is excessive. So that's kind of hypermobility versus flexibility in a really simple way. When it comes to hypermobility, though, it can affect and present differently in different people in different ways. So you can have someone who's hypermobile in a single joint. Maybe they sprained their ankle and ruptured all the ligaments, and they are not hypermobile throughout their body, but their ankle is now hypermobile because those ligaments no longer restrict movement. But you can also have people who have what's called generalized joint hypermobility. And that term describes when we have hypermobile connective tissue throughout the body, affecting muscles and joints from head to toe. It can be regional. So you can have someone where it's more a lower body thing or upper body. But in a general sense, if we just stick with generalist hypermobility to keep it simple, that's kind of the head to toe presentation. It does not mean that even in someone with generalized joint hypermobility, that every single joint is going to be hypermobile. Very commonly, it's a mixture of hyper and often even hypomobile joints. So a really bendy neck with a very stiff thoracic spine is a really classic presentation that I see in clinic. So it is a little bit nuanced. And in terms of how can someone know? If you're someone just in a general sense, you were able to go into a back bend without any training from standing, drop into the splits, that, these types of like party tricks, those types of things, those are signs that it might be good that you start to learn about hypermobility, maybe talk with some appropriately qualified healthcare providers. There are various scales and assessment tools as well. And those can, of course, give a more clinical perspective on whether or not that person presents with it. But if you can do movements that your friends can't do, or if you're that person who's always been like, why are we stretching? Like, what is the meaning of life? In gym class, you're like, why are we all doing this? Then I recommend learning more about hypermobility.
Yeah. Okay. So bendy, but sometimes that doesn't necessarily mean all your joints bendy. But
Yeah.
what about, because obviously this is like for IBS people who've got
Mhm.
gut issues, and what is there any overlap with people who have digestive issues? Because the connective
Yeah.
tissue is everywhere, right? It's not just
Yeah.
joints and muscles and tendons and things.
No, you're absolutely right. So some people who have generalized joint hypermobility will have other types of connective tissue conditions. And it's important to acknowledge that there are a lot of them. So you'll hear the term EDS online. EDS, or the Ehlers Danlos Syndromes, refer to 14 different types of EDS. And 13 of those are rare and ultra rare, and we have a known gene, and they're different. So we're not going to focus on them for the purposes of today. But if you're someone where like you're concerned about things and some of what I'm saying resonates with you, but you have some different stuff going on, just be aware like this is not the whole picture, because we cannot possibly fit that in. But in terms of hEDS and HSD, which are the two most common hypermobility-related connective tissue disorders, and they're increasingly being recognized as being one and the same, essentially. Current management guidelines are to treat them in the same way. Recent research has confirmed that the current diagnostic criteria don't really do a good job of dividing these conditions. So you will hear me say hEDS/HSD while trying not to trip over those letters as I say them. But in those conditions, we have research. There was a study, I think it was 2023 or 2022, and I'm happy to send through the references for your listeners as well, where they took an adult population, and it was like 1.6 million people, and they were looking at these people with diagnosed in their medical records hEDS or HSD, and do they also have IBS? And the risk was 2.5 times more likely that they would have IBS. So it is a huge thing that's present in this patient population. I can say anecdotally for me, I am someone who has diagnosed hEDS. IBS was one of the first diagnoses I received. So it's something which certainly does affect patients. Another study, which was a big survey, I can't remember the number. It was like, I don't know, close to 10,000, I think, respondents, but it was a very, very large survey. It was looking at the complexities of co-occurring conditions. It's by Daler et al. But in this study, what we found was 84% of respondents reported having some type of gastrointestinal diagnoses or symptoms going on, which related to their hEDS or HSD. So you can see it is a very big thing. And it's certainly, after muscle and joint pain, it is the second most commonly reported issue that these patients present with. So they go hand in hand.
Slow transit time, as in, if you think that, I would imagine it that the connective tissue is loose, it's not as powerful, like slow stomach emptying and maybe slow transit time, but could it also present with other symptoms?
Yeah, that's a really good question. So in terms of transit time, what I see in my work, and as an osteopath, I do a comprehensive medical history. So although I do not specialize, like I cannot treat gastrointestinal issues myself or diagnose them, I really try to make sure I pick up on them, because as you know, they can be serious. They can affect people's quality of life. In terms of transit time, what I see in clinic is very much a mix. So I'll often ask people like, how are your bathroom experiences? What are those like? And just to kind of get the conversation going. And there are some patients who have very slow transit times. So these will be people where they're telling me, it's days or even weeks without a bowel movement. And I always make sure to ask, what is your longest time that you've ever gone without a bowel movement? Because there are certain cutoffs where it can become very serious and we need to do appropriate gastroenterology referral and management. But there are also patients who will say, I don't have any issues with constipation. I only have issues with diarrhea. And they will be telling me about a totally very different perspective where they might be having diarrhea. And I hope it's okay to say these words on the, the last episode was on acidic diarrhea. Actually, I did listen to that one. So we can say these words here. Good. But yeah, in terms of diarrhea, these people will be having diarrhea like 4, 5, 10 times a day or something, right? So you have both ends. You also have the people in the middle who say it's never normal And that's like, I wish that was almost an official medical term, because it comes up in my clinic office all the time, where they're like, Alex, they look at the Bristol stool chart with longing, and they're like, I'm the top or the bottom of the chart. I've never been in the middle. Researchers speculate that happens because we get some slow transit, which starts to result in some accumulation of matter in the colon. And then that kind of creates a little blockage. And then you get some conditions which can cause diarrhea, and you get this kind of like altered motility. So kind of like, I know in SIBO you have the IBS, you have alternating IBS type A or whatever it is. And it's kind of like that type of picture where you'll go one and then the other, but just never normal.
Yeah, so it's really confusing, isn't it? Especially if people don't have many joint issues with their hypermobility, and perhaps they see more of the gut symptoms, but they might have a small amount of joint mobility issues, but wouldn't necessarily automatically think. People always go to the food for IBS, but sometimes it is something structural, physical, nervous system related that isn't about what you're eating. It's to do with how your digestive function is working.
Oh, absolutely. I find the simplest way to break it down is I always think in terms of the actual structure of the digestive system. So as you mentioned earlier, we do have that laxity in sometimes the wall. The gut is a tube of connective tissue from mouth all the way down. So that can certainly affect transit times. We also, though, have the immune component. The gut is a major immune system in the body, a contributing factor to that. So we have to think from that perspective. And then, of course, we have to also think from the dysautonomia perspective. So for listeners, dysautonomia is an umbrella term, which refers to abnormal function of think of it like the background processes in your body. Like, I ate some breakfast, but I'm not having to tell my gut to digest it. It's just doing it. So all of those background systems start to get a bit altered. And we can have that with things like POTS, which some listeners may have heard of, or orthostatic hypotension. So other types of cardiovascular, heart and blood vessel related dysautonomia, which affects blood flow to the gut, which can also make it function differently. So it's all really complicated.
Yes. And there's so many of these axes as well. I was just investigating the gut heart axis for somebody the other day, and there's big areas of research, more things are coming out all the time, but it's really interesting that once you start digging into it, there are so many mechanisms by which everything is connected, and you can't get away from just treating like one element. But I guess because the whole symptoms are all connected, that's like part of the key thing. It's connective tissue.
And figuring out where to start.
Where do you begin? Is there a way people, apart from the sort of bendy joints, or like you're saying, that doing the splits and things, is there any other classic symptoms people would watch out for alongside any digestive issues?
Yeah, so in terms of figuring out, like, could hypermobility be relating to my gut issues for your listener?
Is it worth going to the doctor to ask about again, or what could people think?
So I would say if you have chronic muscle and joint pain is a big one. And these will be things where people dismiss them as well. So I was in my early 20s with horrific chronic neck pain. But if you'd asked me in a survey at the time, do you have chronic pain? I would have said no, because I had been told, you're too young for that. You don't have that. I'd been taught to really dismiss that experience. So think carefully about if you have chronic pain. That can be a big marker. Also appreciating that the normal baseline for pain is 0. So someone told me that once, and I had to think on it. And it was a really, profound moment for me, because I realized I'd never really truly experienced a 0. I'd had a 0.5 maybe, or a 1, but like a true 0 is what is normal. So that's, I think, an important thing to be aware of. We also see things like, for example, the 2017 hEDS diagnostic criteria. They are what is currently at the time of recording used to diagnose hEDS. They will change later this year in December and January. But for right now, that has kind of a checklist of some of the various features which are seen in this condition. Some people will have some hypermobility in their hands. So for example, if you're the person who can put on a brace, a bangle of any size, that's something which kind of features right now on the diagnostic criteria. They call it the wrist sign, with a specific way you measure it in clinic, wrapping your thumb and pinky around your wrist, but that might be something. In terms of other things, dental issues are very common. So people who have a high, narrow palate. So to use myself as an example, and to be clear, I just want to stress, I know I'm repeating myself, but this is a very nuanced thing. People need to be seeing healthcare professionals who are informed to be able to help them make an accurate assessment. But a high or narrow palate. So if at the dentist they have to get the child size retainer for you or something, that might be all these little quirky things. They're not so quirky. They can be signs of an underlying connective tissue condition. I would say other things as well. The young person with gastrointestinal issues. A lot of my patients, they were having their symptoms, which were often like mine diagnosed as IBS. They were having them from a very young age. So again, just being aware that it could be something else. And I will say, finally, family history. So if in your family everyone has funny knees, funny hips, or it's normal to click things before you get into place, or everyone finds sitting painful or standing painful, all these like family quirky things that people just say, oh, it's just we have bad knees in my family. It might be worth certainly speaking to your medical doctor about your family history of your musculoskeletal health, which I don't think is done enough because people are quick to say, oh, my grandma had a heart attack. But I want to know, like, what were your grandma's hips like? Because
Yeah.
that certainly is something which we do, we know in the case of hEDS and HSD, they are autosomal dominant conditions. So they have a very strong inheritance pattern, and a child of someone affected has a 50% chance of having these conditions. So family history.
Mm. Yes, important for many conditions, definitely, to know what runs in the family. And I know you've been speaking on Instagram about like the lack of sort of an oversight of this from a medical perspective as well. So when people do go, there isn't necessarily many connective tissue doctors sort of overseeing this condition and really specializing in it.
Yeah, it's a huge, huge problem. So when I have a patient with gastrointestinal issues, which again is something I screen for because I know how problematic they can be, the question becomes kind of like if that person is limited in their self-funding, right? We have to make decisions. Say their NHS GP hasn't been that helpful for whatever reason. Do you go through the immunology pathway first, or do you see the gastroenterologist first? Or ideally, they'd see both if that was possible. That would be the best clinical management. And ideally, again, I try to never make decisions outside of my clinical competence. So I would advise them, speak with your GP and see what they say, and they can make the final decision. But it's really difficult because there's no such thing right now as a connective tissue medical specialty. And that's what we need. We need that. Like, there's no way, there's no ifs, ands, or buts about it. I'll never forget, I had a wonderful young woman as a patient, and both her parents are medical doctors, specialist medical doctors. And she asked me one day, she said, why is there no such thing as a connective tissue medical doctor? And I said, ask your parents. I want to know what they say. So she did. And she came back to me and they said that it was too hard. And I know that it's hard, but the world is full of problems and, sometimes we're able to solve them. And this is one I think where I would be so happy if within my lifetime we saw that as a new medical specialty. And in the short term, what would make me really happy is if every medical history form at every teaching school, whether it's for physiotherapists, osteopaths, or medical doctors, would have a connective tissue section where we can just have some questions or at least prompt students to think, could the patient I'm seeing be affected by abnormal connective tissue?
Yeah. And how common is it, do you think, that people have
Yeah.
this? Is it very prevalent?
So hEDS and HSD present at a rate of at least 1 in 500 people, as per the most recent research. So there's a whole section of my book on like what is rare, what is common, because we don't think about what those terms like literally mean from a statistical perspective. Rare is generally defined as occurring at a rate of less than 1 in 2,500 people. So 1 in 500 is thoroughly not rare for hEDS and HSD. In terms of generalized hypermobility more generally, we see that at a much higher rate. And unfortunately, as you know from looking at research, sometimes with studies we get a huge variability in findings, but it tends to be, I'd say, about like 1 in 4 adults, 1 in 5 adults will have some degree of hypermobility present in how they move. And again, there are people with what's termed as asymptomatic hypermobility, where they will be hypermobile. And you will see that they have hypermobile joints, or at least I will. And they will say that they are fine and they don't have pain and they don't have injuries, they don't have gut issues. So some people's bodies are just less affected than others.
Mm. And is the way they get affected because of the overstretching and then the pain and the aching in the like for joint pains?
Yeah, I think often it is. It's a combination of a few things. So some people are just quite unlucky, I think, in terms of
Mm.
how affected their connective tissue is. So it is very much a spectrum. There are people with HES and HSD who have extremely serious health issues, and there are people who are more mildly affected, like myself, where I am able to, do certain types of exercise and live my life in a relatively, unremarkable way. In terms of how do people kind of end up, I guess, or kind of what is the interaction between the environment they're in and their connective tissue, and how can that affect things? You can, I suspect, have someone who has asymptomatic joint hypermobility, who maybe does lots of tennis or sports that are taking that tissue to end range, and theoretically, maybe they're at a greater risk of injury. We don't have that much research right now on these very mild presentations, but what I see in my patients is it's often not just like what they've inherited in their connective tissue, or, what they have. It's how has their life affected them. So for example, what has their career demanded of them? What sports did they do in childhood? I was a butterfly swimmer. I had lots of shoulder issues. I am not surprised,
Yeah. Overuse or
Yeah.
like repetitive use of certain joints. Yeah.
Yeah, and again, this is where part of, I think, a big problem lies with current guidance is a lot of patients are told, "Oh, just go swimming, just do this." And it's like swimming can be good for some people, but if you do too much of it, or if you're doing it with hypermobile joints in ways that are injuring you, then it's not going to be good. Interestingly, I will say a lot of my patients, they find that exercise is one way that they're able to positively affect their gut health. And I think that goes back to parasympathetic effects
Mhm.
of moderate intensity cardiovascular exercise. I've always been obsessed with moderate
Yeah.
intensity cardio, and it's nice to see
So
it
like
kind
just
of,
helping them calm down, helping them like to
yeah.
release stress, so reset your breathing. You mean from that like physical perspective of that it helps your nervous system,
Yeah, that's what I
yeah,
think it's
breathe.
doing, and for me, I was at a gastroenterology, conference. It was on hypermobility and gastroenterology, so I was really excited to go to this a few years ago, and, of course, they're talking about medications, which are great, and there are medications for anyone listening, there are medications that can help patients, whether it is an immune-mediated cause, whether they could have, SIBO and something. You can always have and. You could have
Yeah.
IBS and SIBO and gastroparesis, which just refers to slowed motility in someone, often people with hEDS or HSD. But you can always have and in the diagnosis, unfortunately. But I went up to a gastroenterologist at this conference and I said, "Hey, I just want your opinion on this because I feel, I want to know if I'm thinking through things correctly. I'm someone with hEDS. I find that when I don't exercise, my gastrointestinal symptoms get so much worse. And when I do some moderate cardio, I find it really helps me. Does that make any sense?" And she was probably slightly confused for a sec when I went up to her with this question, but she said, honestly, she's like, it does make sense from the perspective of how it helps to regulate the nervous system and from how it helps with blood flow as well throughout the body. So we're just forcing blood to move around. And if you're someone with POTS or other conditions that are similar to that, then we get issues, which puts stress again on all these systems in the body and the functionality of them. So it was nice to have some validation, and of course, nice since to look at research. And we don't have research on exercise and hypermobility and gut function. So I'd love to see studies on this very much. But it was really nice to get that validation for kind of one intervention that certainly helps me and that I try to support my patients in using when it's safe and appropriate for them.
Yes, and the other thing is moving, walking or light jogging, it just jiggles everything around, it
Yeah.
can let the gas out, keep them
Yeah.
like encourage better bowel movement just because it's physically jiggling everything around inside you. So
Oh,
so
absolutely. I
that
come from a
muscle
sorry, go on.
can help. Sorry.
No, I was just going to say I come from a long family line of people with Crohn's disease as well, who probably were diagnosed or had gastrointestinal issues their whole life, or I can say who did, based on what my mom and grandma told me. And family walks after dinner were very much a routine. Let's put it
Good.
that way.
Yeah. Yeah. I think they call it a fart walk now on Instagram and TikTok.
So my mom and I called it a putt-putt walk. So-
Yes, very good. Okay, so yeah, I mean, that's one thing that can be helpful is keeping active or,
Yeah.
not overstressing yourself, but definitely keeping movement in as
Yeah.
part of your day. Are there any other things that people would do well to, there's must be tons of strange diets and things you come across people trying and supplements being marketed at this as well. Is there
Yeah.
a range of things that are actually helpful from a research perspective?
Mm. Yeah, it's the Wild West out there right now. Like social media has become stressful place,
Yeah.
shall we say. So please, like, listener, beware if you're on social media, for sure. In terms of supplements overall, my number one resource for patients, I don't know if you use it, but examine.com is my favorite site ever. Yeah,
Cool.
you know what it is. So
Yeah.
basically, I've been using it since 2015. So back in the day, I was like on there trying to figure things out. What they do is they take all of the published studies and synthesize the research and present it in tables with references. So if you're someone who wants to know, like, what is magnesium? How much can I take? What should I avoid taking it with? People don't often think about interactions between supplements or supplement medication interactions. I think certainly having greater awareness in the public of resources like examine.com is really helpful. In terms of supplements as a whole, there are a few things I like to touch base with patients on. So fiber can be friend or foe. People have very complex relationships with fiber. And again, I'm not a dietitian, I'm not a gastroenterologist, but I know that fiber is an important thing for people to have if possible. And often patients who see me, they are on very low fiber diets. So I will try to support them in speaking with an appropriately informed healthcare professional about seeing if there are ways to safely and gradually increase their fiber intake if it's possible for them. Hydration is a big thing. So water as well as electrolytes. So in really simple terms, some people who have POTS or orthostatic hypotension, so these co-occurring kind of cardiovascular conditions, which are common in people who are hypermobile, they can be like me growing up, and you drink a big glass of water, you fill it all up, and you drink a second one because you're so thirsty. But then shortly after, you're going to the toilet and having clear urine, basically, because your body's not taking it in. We rely on an osmotic gradient to actually pull water into the body. So certainly having some electrolytes or some salt can help. Again, please do not get scammed. There are lots of rip-off electrolyte companies. Find
Mhm.
something that is cost-effective and works for you. I just like to eat a bit of extra salt in my food. I find that's an easy way for me to do it. In terms of other things that tend to help, when it gets to more nuanced recommendations, that's where I leave it to the professionals in this field. But being aware as well that some patients can, even because of their gastrointestinal issues, have nutrient deficiencies sometimes, because if they're having such frequent diarrhea or they're not able to absorb those nutrients, that's just something I try to be aware of with my patients. So just having them comprehensively assessed and doing a really good referral tends to be my approach there. In terms of other things, I think being aware again of the importance of kind of having a balanced diet. So trying to get, if it's possible, getting some calories in early in the day. A lot of my patients tell me they wake up with nausea and they have a hard time getting some food
Mhm.
in. We talk about regular bowel habits, and I think we need to remember regular eating can help with regular bowel habits. So trying to make sure that we're not, going all day forgetting to eat. Maybe a lot of people with HEDS and HSD have ADHD, which can complicate things further. But trying to get that food to intake in to help with that gastrointestinal regularity. And again, I'd say just being aware of the issues with highly restrictive diets. Again, there are some cases where they are appropriate, but that's between the medical doctor and the patient. That is not my remit, or the dietitian or whoever is the appropriately qualified healthcare professional. It's not my thing that I do. But when I see patients who tell me, like, Alex, I'm only eating like sour candies and apple juice or something random. That is an actual example I had, by the way. I'm like,
Oh,
we need to have a talk about this. I do see a lot of patients with ARFID, avoidant restrictive. I'm going to mess up the acronym, food intake
I did,
disorder.
yeah.
Yeah. And I think, again, like, I've had periods in my life where I've had to just find what kind of works. And I would eat the same thing over and over and over again. But being aware that having a balanced and varied diet is important. And just knowing that, like, it's not in your head, it's not anxiety. If you've been, assessed and you're trying to manage, say you have had that IBS diagnosis, but say that you're not getting the results that you want to get in terms of your symptom management, just being aware that there could be an underlying complicating factor at play, I think is super important.
Yes, and then that there is potentially help out there. Like you said, there is some medications that can
Yeah.
ease some of these symptoms. So making sure that you're going back for another assessment and kind of not putting up with it as well. Like you said, people get so used to a low level of pain or a low level of constant bloating that it kind of becomes your new normal. And then
Yeah.
when you realize that there is a way of resolving it,
No,
it can be life-changing.
absolutely.
Yeah.
It's people don't realize how heavy the bag that they're carrying is until they
Mm.
put it down. And it's heartbreaking. Like, I find it hard to think about even for myself, it's something like, it is not normal to have bloating every day. It is not normal to have pain every day. It's not normal to be anxious when you're going out for a meal or eating food. Like, all of these things are not normal. And that's why I'm so grateful to people like you who run podcasts and talk about things like, because I'm often the first healthcare professional who's asked my patients, how are your bowel habits? Do you have issues with diarrhea or constipation? Like, just this really direct questioning, because I want to know, because I know how much it can affect people. And going back to the hypermobility aspect, these are patients where if they're having frequent gastrointestinal issues, they're going to be fatigued. They're going to not be feeling
Mm.
well. That's going to affect their ability to exercise. By not being able to exercise, they can't build muscle mass. Building muscle mass and strength is one of the best treatments we have for muscle and joint pain. So it's also interconnected. And although the field is quite small, it is growing. I was so excited to see you mention hEDS in your book. I think it was page 9. I like circled it or something, but I was like,
Ah,
we're starting to see it appear, in
mm.
different places, and it gives me a lot of hope for the future.
Yeah. And what kind of, you mentioned strength training, and obviously you do work with giving people exercises and that sort of thing. So is building muscle, lifting weights or just using their body weights? Like, what kind of exercises are typically recommended?
Yeah, I would say the best exercise is always what the person can do without
Mm.
injuring themselves or worsening their
Okay.
symptoms. And we have to remember that muscle and joint pain and also fatigue and dysautonomia, also all these other symptoms, can go hand in hand. So we always have to treat the person as a whole. With my patients, I like to first start with any exercise program by asking them what they enjoy. Again, it's because when you have chronic health issues, enjoyment's really important. And I can tell you, this is the most evidence-based approach or whatever, but the truth is right now there's no real consensus on exercise for people with HEDS or HSD. So there is a lot of variability in terms of how practitioners and healthcare providers will approach this. Going back to my patients, what I tend to do next with them is talk with them about the pros and cons of different types of exercise. I'm a big cardio fan, so that is the foundation of my personal exercise routine. I do strength training. I do a lot of strength training and have a lot of muscle mass. But when I'm feeling poorly, I go back to moderate intensity or steady state cardio, because I know that it's the quickest way to get myself feeling less bad so I can do the strength training. So that's what works for me. There are some patients where, for whatever reason, and it can be underlying health issues of different types, or maybe they just hate it. Maybe they're people who hate cardio and they don't want to sit on a bike and be bored for 20 minutes or whatever. So there are some people where strength training is going to kind of be the foundation of their personal program. So if there's not a specific underlying injury, like say they come with an ankle sprain, we're going to do an ankle sprain rehabilitation program for that, right? But if they just come to me and they're like, Alex, my everything hurts, what can I do? I want to start to feel better. Working with what that person brings to the table will always lead to better results. I will say one change I've made in the last couple years is I really like to focus on girdle joints in the body. So I specifically will look at the shoulder girdle, especially the scapulothoracic joint, so where the shoulder blade sits on the back and the muscles in that mid back. Sorry, I keep banging my my little headset today. I talk with my hands too much. But I will look at that hinge where the arm attaches to the body. But I will also look at the lumbopelvic region very much, so the hip flexors and the hips. So it's hard because it's like with the gastrointestinal issues you deal with, there are so many places you can start. But if I'm trying to find the place that's going to get someone results fastest, specifically from a strength training perspective, I'm going to be looking at where your big heavy arms attach to your body and where your big heavy legs attach to your body, which is going to be those types of girdle regions.
Okay. Yeah. So holding it all a bit more upright and like being able to just keep your body still
Yeah,
and
and
stability.
building the muscle mass to let you do that passively. So I'm very against people, the posture police. I don't tell my patients, and I actually think it hurts people when they say, you have to have upright posture all the time. I think it's incredibly fatiguing, and I think it's not possible for most people with this condition. I'm a big fan of lying down, and I do occasionally slouch because it's comfortable for me. So hopefully the posture police won't get me. But what I do like to help people do is have excellent posture by helping them develop really strong lats. So the big muscles on your back, we want
Mm.
a lot of muscle mass there. Interestingly, the lats, so they start quite low down, right at the top of the glutes, basically. So that upper part of the pelvis, the thoracolumbar fascia, the lumbar spine, and so on. And they go up and they actually attach to your shoulder blades and to your arms. So we have this big flat muscle that kind of spans the whole of your back and even attaches onto your arms. So I am a huge fan of lat development, but I do find that lat pull down machine, which is what an average listener would probably go run to, I find that those tend to injure people just because they get you in a position where you can kind of start to use the wrong muscles. And again, it's not anyone's fault. You're just doing what your body lets you do. But I don't really trust myself to use a lat pull down machine. So I like to do more targeted exercises using bands where I'm kind of knowing that my body will always try and do the path of least resistance movement and then encouraging it to do the movement it needs to do. So definitely for any listeners, if you can find someone who you gel with, who has a background ideally in working with people who are hypermobile, that is one of, I think, the best investments people can make. There are some personal trainers and strength and conditioning coaches I refer to, and I work with one, and I've worked with a few over my lifespan. And I really do think it's a very underappreciated profession because they have probably in some ways, like they have certainly saved my quality of life. I can say that. And in terms of my gastrointestinal health, by them helping me stay physically active, they probably helped with that too.
But I guess you need to know someone who understands the condition as well. If you just get a standard
Yeah.
PT in a gym, they may not really have this understanding.
Yeah, most of them won't right now. So ideally, you would see a healthcare professional of some kind who's very well
Yeah.
versed in hEDS and HSD. So this is how I manage my patients. Patients see me. I talk to them. We talk to other medical doctors if required or medical specialists to make sure they're safe to exercise because that's number one. Some patients will have things like post-exertional malaise where exercise actually makes them feel worse. They get this almost flu-like
Yeah.
response. So there are people where we really don't actually want them, right now at least to be exercising. So we want to make sure that we only have the right people who need to exercising, which again is the majority, but we just always want to be cautious and not miss these people where it can be problematic intervention. And then the best situation, and this is something that I really learned from my work with professional athletes, is when we get I do this triangle symbol, but we want the patient, the coach or the personal trainer, and the healthcare professional to work as a team. So whenever I refer patients to personal trainers or to strength and conditioning coaches, I tell them, I'm like, I want updates. I want to, let me share. Let's make a group chat. Let's talk about this. I make sure I get the patient's consent, of course, but I think it's that team approach that really helps at the end of the day to get the patient the results that we're trying to help them get.
Yeah, that sounds really powerful. Very good. Cover it from all angles. Yeah.
Yep.
Amazing.
And second
And
set of eyes, that's what
yes.
helps a ton
Yeah.
too.
But it's the people who really understand the condition. I think that's the difference. As specialism makes a big difference. You can just go to a generic osteopath and they may not have the same level of insight into this. I mean, you've written a whole book about it. You've spent years researching it and, really digging into all of that. And yeah, it's a good resource for people. Yeah. Is there anything else you'd like to finish with? Things we haven't covered that you think is really important for people if they're not so familiar or they're maybe not sure if they have this that they would need to know?
Yeah. I think couple quick things. So one thing that always stays in the back of my mind, even when it comes to my own health, is that we had our kitchen renovated recently. I think we got 5 quotes from different builders. For health, people will often just see one person. And I think it's important to remember that there are different levels of expertise, different training backgrounds, different areas of clinical interest, and even just different personalities. I've seen healthcare providers where I just didn't like them as a person, So, and again, of course, there's different contexts. If it's an emergency, I will be grateful for whatever medical doctor will help me out in that situation. But when it comes to chronic health conditions where you kind of have to have a long-term working relationship with the healthcare provider you're seeing, I think if possible, certainly try to reach out or do your research with different people, to try and get a feel of what you can reasonably expect and what good looks like and what not so good looks like. I think as well, it's important to be aware that incurable does not mean untreatable. I cannot think of a time where I've seen a single patient where there was not at least some theme that could be improved. And that's kind of the beauty, as much as it's hard, the complexity and this whole multifactorial nature, all these different axes, as you mentioned earlier, that's also kind of the beauty of it, is that once we find an in and we can improve one thing, that often does create an environment where more improvements are possible. And it's really that strategizing and problem solving and finding that in, which I think is so important. So just remember that incurable does not mean untreatable. And I think we really need to stop normalizing poor gastrointestinal health in people, and especially in young women. I know a lot of the patients I see, they are females, and these are people where, girls are not supposed to have flatulence, or these types of things, or fecal incontinence is something some of my patients have as well. So I see serious gastrointestinal issues in some of my younger female patients, and we need to normalize discussion of this because it's so critical to know you're normal, because sometimes people can have serious changes in their bowel behavior, which require time-sensitive investigations. And if we don't make young people especially feel comfortable talking about this, then how can they have a chance to feel comfortable speaking with an appropriate healthcare provider if they do have a serious change in their bowel habit? So I want everyone to talk about bowel issues more often. So thank you for having me on.
No, very good. I felt like, throughout this, there's so many things I've been like, ding, 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 like it really just aligns with my approach in terms of, fueling well for exercise, like, the benefits of exercise for the whole body, and so many of the things you were saying about, So I'm really, it's been really lovely to chat to you. So can you tell the listeners a little bit more about your book and also where they can find you?
Yeah, so my book is called Help, I'm Hypermobile, Your How-To Guide to hEDS, HSD, and Life in a Hypermobile Body. I wrote it just because I was having the same conversations day in and day out with patients, and I wanted to be able to give them a very simple explanation of just some kind of standard information, but presented in a way that's hopefully informative and engaging and hopefully enjoyable to read. That book is available on Amazon. It's you can find it through all my social media. If you can't find it, message me. I will make sure that you find it. It's available as an ebook. It's available as a paperback, and audiobook will be out later this summer. So it will be available in different formats. The first half is a little bit of anatomy and physiology and discussion of everything I wish patients knew before they saw me or before they started to try and almost make progress in a system which doesn't really have a clear path for them, unfortunately, in a lot of countries. So it's what I would equip people with and what I wish I had had for myself. The second part of the book is an FAQ. So all the questions patients ask, there are some very standard questions and also some kind of more interesting questions in there. So it's kind of a two-part book in that respect. In terms of finding me, so I have a very Canadian accent, but I am based in London, UK. I've been here for 13 years. I have a clinic office in Marylebone. So that's where I see patients in person. I do see patients online as well. So I do an online clinic on Thursdays each week. You can find me on social media as well. So I am on TikTok, Hypermobily HQ, Instagram. I'm on YouTube, and I also have my own podcast called Help, I'm Hypermobile. So yeah, that is, I think, everything that I need to say.
Great. That's really helpful. So I'll signpost all of that in the show notes. And thank you so much, Alex.
Thank you so much for having me on, Anna. It was truly a delight to be here.
Do go and look up Alex's social media, go and find her book. It is packed with really interesting information. It's so enlightening. So I really suggest you follow her. You can find her website as well in the show notes. Thanks so much for listening to this episode of the Inside Knowledge podcast. Better digestion for everyone.